Very good morning, respected chairpersons, my dear colleagues and friends, ladies and gentlemen. Although the topic of my talk was given as premature ovarian failure, I would prefer the term premature ovarian insufficiency because if you know the recently published guideline on FOGSI, they recommended using the term premature ovarian insufficiency rather than premature ovarian failure. Why? Because the word failure indicates some sort of incapability in the women. Therefore, rather than using the term premature menopause or premature ovarian failure, the preferred term is premature ovarian insufficiency. Why not premature menopause? Because ovarian activities can fluctuate and some women can have irregular periods and some even can conceive. So, it's basically the cessation of ovarian activity before the age of 40 years. Now, if you see this guideline, there are several parts. The number one is the definition of premature ovarian insufficiency. Now, why this 40 years was taken as cutoff? Because throughout the world, the median age of menopause was found to be 50 years. So, taking into account the two standard deviation, they used the cutoff 40 years to define the premature ovarian insufficiency. How prevalent it is? Earlier study it showed it's not more than 1%, but the recent study showed that it may be as high as 3.5%, and there are some other women who are having menopause between 40 to 45 years of age, and in this case, this condition may be defined as early menopause. Now coming to the diagnosis. Typically, it is said that oligo or amenorrhea for at least 4 months duration and elevated FSH more than 25 on 2 occasions at least 4 weeks apart. But the question is, do we need to check FSH regularly? Do we need to repeat the FSH? The answer is no. Single FSH is sufficient. You should repeat it only when there is some confusion. And in contrary to our common perception, in these cases, FSH can be checked any day of the menstrual cycle, not only on day 2 or day 3. That is, you can check FSH randomly and diagnose it. However, if the woman is taking any hormonal medication, in that case, it should be stopped at least 3 months before checking FSH. Other testing like serum estradiol or scan to check antral follicular count can give additional confirmation, but these are not absolutely necessary. Serum AMH should not be checked routinely, can be checked only when the FSH is inconclusive. Now, coming to the etiology. Before going for diagnostic test, we should explain to the women that in 70 to 90% cases, the diagnosis may remain uncertain. However, comprehensive genetic tests like NGS can reduce the prevalence of quote-unquote iatrogenic and quote-unquote idiopathic POI. Now, the diagnostic algorithm. If the woman underwent some like bilateral salpingo-forectomy or previous chemotherapy, you don't need any diagnostic test. Straightforward level the woman is having POI. Otherwise, go for genetic testing, karyotype, fragile X mutation, and if possible NGS. If there is any abnormality, this is genetic POI. If these are normal, then look for endocrinopathy. Check only antibodies against 21-hydroxylase and thyroid level. If these are abnormal, then endocrinology referral and term it as autoimmune POI. If all these are normal, then use the term idiopathic POI. Now, why genetic testing are required? It gives some psychological benefit to the woman that is, my doctor is able to diagnose my condition. It's not something idiopathic. Next, oncological risk, because if you find Y chromosome, because it may be responsible for POI, the woman is at risk of developing ovarian cancer, so you need gonadectomy. And again, this POI may be the part of syndromes like Turner syndrome and other genetic syndromes which may affect renal, cardiac and other systems, so the appropriate treatment strategy can be planned. Next, the first degree female relatives are at risk of POI, so they can consider fertility preservation. And not only the female relatives, surprisingly it was found that brothers and sons of these women are at risk of developing azoospermia and oligospermia. So it will help you to counsel the family members as well. And probably in the next few years, we can have some gene therapy based on these genetic mutations. But it's important to counsel the woman before we do genetic testing because it may be transmitted to the offspring because some of them can conceive naturally And karyotype should be done for all women irrespective of age. Previously it was said that karyotyping should be done only before the age of 30 years in POI. Now it is said that karyotype should be done in all women because it can reveal Turner, mosaic Turner, triple X and structural abnormalities in the X chromosome. And fragile X mutation should also be done because it can be transmitted in the offspring and offspring can suffer from mental retardation. And if possible, if the woman can afford, ideally the NGS should be done. Sorry for this busy slide. Why NGS should be done? Because there are lots of syndrome which can be associated with POI. Therefore, only way we can diagnose this syndrome is by NGS because POI may be the first symptom of these syndromes. Now coming to the immunological testing, 21-hydroxylase, if it is positive, we should refer the woman to the endocrinologist to rule out Addison's disease. If this is negative, there is no need to repeat it unless medically indicated. TSH testing should be done at diagnosis and every 5 years unless there is any other clinical indication. But what I have been told in previous guidelines that anti-TPO antibody should be checked in all women with POI. Now the newer guideline is suggesting that, and because anti-TPO is so much prevalent in normal female population, it should not be tested routinely unless there is any other clinical indication. Now risk to the female relatives. In general, the risk of POI in any woman in absence of family history is 3.5%. However, if there is positive family history in mother or sister, the risk of POI increases to as high as 15%. So how we can manage them? We should counsel them that yes, you are at risk of POI, so ideally you should not delay pregnancy. Of course, in non-judgmental manner, we can't force them, just take the pregnancy. Next, they can consider fertility preservation. Unfortunately, there is no treatment strategy that can prevent POI, but of course we should encourage healthy lifestyle and cessation of smoking, and of course genetic counseling should be done because the underlying genetic condition may be transmitted to the offspring. Now, sequel. The most important complication of POI is cardiovascular morbidity and mortality in absence of hormone therapy. Therefore, in addition to hormone therapy, you should encourage to adopt healthy lifestyle, that is cessation of smoking, maintaining balanced diet, maintaining normal weight and normal physical activity. Now, fertility. POI definitely decreases the chance of natural conception. Still, some women can conceive naturally. Therefore, if the woman doesn't want to conceive, we should tell her to use effective contraception. And unfortunately, no fertility intervention can predict or improve the chance of natural conception. Therefore, in vitro activation, stem cell, PRP, none of them are found to be effective in women with POI. Therefore, oocyte donation is the standard treatment in these women. However, before they are contemplating pregnancy, we should check the obstetric risk. Fortunately, for most women who can conceive naturally, they are not at risk of having higher risk of having obstetric complications, except when the pregnancy occurred after uterine or pelvic radiation, and of course if there is oocyte donation pregnancy, they are at risk of developing preeclampsia. Therefore, it's important to encourage the woman when we refer to them to the obstetrician. It's important to tell the woman, please disclose it to your obstetrician that you conceived after oocyte donation. And of course, you know, if this is a case of Turner syndrome, there is increased risk of cardiac, non-cardiac and obstetric complications. So therefore, we should check the fitness for pregnancy before they are planning for pregnancy. Okay. In all cases, renal and thyroid function should be checked. If it is autoimmune, then we should rule out the Addison's disease. And if the woman receives some certain chemotherapy like anthracycline or cyclophosphamide, cardiac function should be checked. And of course, cardiac function checking and renal function checking is mandatory if this is a case of Turner syndrome. Now, bone health. Women with POI, because they are young, they are deprived of estrogen, they are at risk of osteoporosis. Of course, there are some additional risk factors which can lead to osteoporosis. Therefore, it is recommended that in all cases, the DEXA scan should be done at diagnosis, and if it is normal, it should be repeated every 5 years. Healthy lifestyle makes sense, but the most important thing to prevent osteoporosis is the hormone therapy. And the second line of treatment is anti-resorptive therapy, that is bisphosphonate. But if you are advising bisphosphonate, advise effective contraception because these medicines are potentially teratogenic. We often are concentrating only on bone health, but muscle strength is also compromised in case of POI. There is risk of sarcopenia and there are some diagnostic algorithm based on the muscle strength, quality and quantity and performance. And again, the treatment is hormone therapy and lifestyle changes. Now, in men with hypogonadism, testosterone can improve the muscle strength, but whether the testosterone can improve the muscle strength in women with POI is not known. Now, most important thing, the cardiovascular health. These women are at risk of increased cardiovascular morbidity. Therefore, in all women with POI, we should check routinely for blood pressure, smoking status, lipid profile, diabetes. And if there is Turner syndrome, they should be seen by a cardiologist. Lifestyle changes are the first line of treatment, but most important thing is the estrogen therapy. Remember, these women are relatively younger and they are deprived of estrogen. And otherwise, the physiological demand of estrogen is very high, and the risk of breast cancer and thromboembolism is minimum in these women. Therefore, this is the hormone therapy that is the only thing that can prevent the cardiovascular mortality. And sexuality. POI affects sexuality, therefore we should routinely ask every aspect of sexuality, including the libido, the lubrication, orgasm. Hormone therapy can cover some aspects, but not all aspects of sexual health. Most important therapy in this case is the testosterone therapy. Ideally, that should be given by transdermal if there is hypoactive sexual disorder. However, we don't know whether testosterone improves the other parameters apart from hypoactive sexual disorder. And remember, the long-term safety rate of testosterone is not known because testosterone is converted to estrogen in the body. Therefore, when the estrogen is converted, we can't give testosterone. Now, genitourinary symptoms may not be covered by systemic HRT. In that case, we have to think of giving the vaginal estrogen therapy. Sometimes vaginal lubricants and moisturizers can be used, but unfortunately, laser and thermal therapy in these women are not supported by very strong evidence. Now, again, these women are at risk of developing Parkinson's disease, dementia, and other cognitive disorder. Therefore, think twice before you are planning for bilateral oophorectomy for benign disease in women less than 45 years. And again, it's the hormone therapy and lifestyle changes that can prevent the cognitive dysfunction. Now, last is the treatment. Hormone therapy is the only treatment for POI. It should be continued at least the age of natural menopause, irrespective of whether the woman complains of any estrogen deficiency symptoms or not. And after the age of normal menopause, that is 45 to 50, consider the risk-benefit ratio and consider continuing the hormone therapy. What's the principle? Physiological replacement is required, and you know if there is presence of uterus, you need estrogen, progesterone both. Non-oral estrogen is preferred if you want to bypass the hepatic metabolism, particularly in high-risk women having liver disorder, malabsorption or thromboembolism. Estrogen requirement is higher compared to women who achieve natural menopause at normal age. Because if you are using higher dose of estrogen, you need higher dose of progesterone for endometrial support. Remember, hormone therapy is not contraception. Therefore, if the woman wants to conceive, she can use sequential hormone therapy. But unfortunately, this hormone therapy in POI women are not supported by very strong RCTs. Mostly these are chosen based on individual preferences rather than the evidences. And remember, hormone therapy in these women does not increase the risk of breast cancer. Of course, if there is unscheduled bleeding in hormone therapy, it should be checked. How we can monitor at least annual visit, cardiac assessment, liver function, thyroid function, and on any new indication or contraindication to HRT and adherence to HRT, that should be checked. Now, there are different regimes, sequential and the continuous regime. I am not going into details. Now, comorbidities. If breast cancer survivor, it is contraindicated. But if the woman is carrier of BRCA mutation and she underwent risk-reducing oophorectomy, hormone therapy can be prescribed. Similarly, for migraine, transdermal therapy or dydrogesterone can be preferred. Hypertension, diabetes, obesity, these are not contraindication. But if there is endometriosis, even if the woman underwent hysterectomy, progesterone should be added, otherwise there is increased chance of recurrence. In malabsorption, we can use transdermal route, but known cardiovascular disease is a contraindication, and if there is abnormal liver function, then we can use transdermal route. If the woman is a survivor of squamous cell carcinoma cervix, hormone therapy can be used. If there is cervical adenocarcinoma or early stage uterine and endometrioid carcinoma or epithelial, non-epithelial ovarian cancer, hormone therapy may slightly increase the risk, but considering risk-benefit ratio, you can start it. But if there is hormone-dependent uterine or ovarian cancer, hormone therapy is contraindicated. On the other hand, if the woman receives the hematopoietic stem cell transplantation and chemotherapy, hormone therapy does not increase the risk of recurrence, so it can be used. Non-hormonal therapies are only options only when hormone therapy is contraindicated, because the hormone therapy is the treatment of choice. Now, regarding induction of puberty, because some of these women can present with delayed puberty, remember, oral contraceptive pills should not be used to induce the puberty, because if you start with very high dose of estrogen in early age, it can cause epiphyseal closure and cause delay in a problem in growth. Therefore, start with low dose and gradually increase the dose. However, if the woman is receiving growth hormone, where the epiphyseal closure is not a concern, you can start with higher dose. Start progesterone only after 2 years of unopposed estrogen therapy, or only when there is breakthrough bleeding. Remember, I have basically covered the guideline, but guidelines are there to guide the healthcare professionals. They cannot establish a standard of care and should individualize the patient, and these guidelines cannot override our healthcare professionals' clinical judgment, and these are subject to change. Now, a little bit of blowing my own trumpet. I was one of the reviewers of this guideline. Thank you very much for the patient hearing.